Morning, everyone. Whoa, it's loud. Welcome to Department of Surgery Grand Rounds. Hope everybody had a great Thanksgiving holiday. Look forward to a nice holiday through the first of the new year. I would guess about half our audience is still sitting on 225 coming north, which is where I was until just a couple minutes ago. So we'll probably have some more people coming in. I'd like to introduce our first speaker, who is Dr. Whitney Jenson. Dr. Jenson is with the Division of GI Trauma and Endocrine Surgery. She received her bachelor's degree at Texas A&M University and then also received a master's of public health in Texas. At Texas Tech, she received her MD degree and then a residency in general surgery at UTMB. When I had been in Colorado for 3 weeks, when I came in 1990, it was the longest I'd been out of Texas in my life. So I know those areas well. She did a residency in general surgery at UTMB, as I mentioned, and then a fellowship in trauma and critical care. This morning, Dr. Jenson is going to be talking about multidisciplinary simulation and trauma education, something which I think is really gaining a lot of momentum, is certainly an important part of our teaching program. So it is great to have you with us, Dr. Jenson. Appreciate you being here and look forward to your presentation.
Good morning. Today I'll be going over some of the challenges encountered in trauma education, how we can use simulation-based education to overcome those challenges, and the more widespread benefits that have come from the mock trauma program. Just as a little bit of background, I've been in charge of the mock trauma program for about 3 years now. We used to do biannual clusters of simulations, 4 in the spring and 4 in the fall, but though we were seeing some really good improvements in clinical performance, those improvements tended to taper off pretty quickly over a couple months. So we've now moved to doing monthly simulations in an effort to create more sustained change. Thank you. So we do in situ multidisciplinary mannequin-based simulations. It just means that we are actually performing our simulations downstairs in the trauma bays with the staff who are on duty at the time, including our own residents and attendings who are on service, so that we can create as realistic and as much of a high fidelity simulation as possible. Education for trauma resuscitation is difficult for a number of reasons. First and foremost, the trauma resuscitations tend to be low frequency, high acuity situations. Even at large academic level 1 trauma centers, exposure to high acuity trauma resuscitations and procedures can be limited, especially when it comes to special patient populations such as pediatrics or pregnant patients. Trauma resuscitations are time-sensitive, highly complex patient care events, which necessitate execution of multiple tasks concurrently for optimal patient care. This often means that there is not time for education during the resuscitation itself. Additionally, trauma teams are generally composed of ad hoc members from multiple different specialties, including residents, attendings, APPs from both emergency medicine and from trauma, as well as nurses, techs, respiratory techs, and pharmacists. So it's a really big group of people. This leads to a lack of shared with large groups comes a large variation in knowledge and skills, which tends to lead to a lack of a shared mental model about how resuscitations should run and what each person's individual tasks and responsibilities are. Overall, the lack of a shared mental model can affect overall quality, efficacy, and efficiency of trauma care. The large pool of people that participate in trauma resuscitations also makes it difficult to disseminate information about changes in protocols and practices. Lastly, because of the need for rapid intervention, this can often leave little to no time for assessment of the care that was delivered and provisions of feedback to improve future performance. The ad hoc nature of the trauma team also means that there's very rarely any opportunity to reconvene the entire team so that we can debrief as a group. All of these difficulties can be overcome with the use of simulation. We know that things like time to transfusion and time to hemorrhage control can have significant impacts on mortality after trauma, which means that trauma resuscitations must be fast and efficient. Using simulation allows us to slow down the resuscitation process and to take patient outcomes out of the picture so that focus can shift to education about specific trauma resuscitation topics. Participants can then focus on why we run resuscitations the way we do instead of being consumed with task completion. This deeper understanding improves performance and increases buy-in for tasks that may have otherwise seemed menial or unimportant. We use high fidelity mannequins with monitors that show minute-to-minute variations in vital signs so that we can react to interventions that the team performs in real time. This means that the scenario can adapt to the actions of the team so that they can see the natural history of their management. Simulation is ideal for learners with large variations in skills and knowledge because each person can take something different out of the experience. By repeatedly discussing the basic principles and goals of trauma resuscitation, every person in the room is prepared to not only perform their specific tasks, but is also empowered to make valuable suggestions to the team leader based on their observations during the resuscitation. Recurrent simulation has been shown to increase the confidence and medical knowledge of participating providers, as well as decrease the time to intervention and task completion, all of which lead to improved care. Simulation-based education also comes with built-in time for assessment and feedback, which is essential for higher level integration of knowledge and is key to sustained impact of this type of education. One of the important concepts in simulation-based education is that there should be a variety in the types of feedback learners receive. After our simulations, feedback is first solicited from participants themselves and then provided by the facilitators. This allows time for self-assessment and helps to create self-learning or self-driven learning after the resuscitation is completed. Procedural sim not only increases comfort with trauma-related procedures, it also decreases the time to intervention for key procedures. One study demonstrated that it was particularly useful for resuscitative thoracotomy, tube thoracostomy, and percutaneous arterial sheath placement. In addition to acquisition of technical skills, in situ simulation allows for team members to familiarize themselves with the locations and types of equipment available, how to overcome logistical issues, and to develop contingency plans. Skills that we have practiced in mock traumas include intraosseous needle placement, application of pelvic binders and hair traction splints, chest tube placement, intubation, and cricothyrotomies, all of which are very time-sensitive, life-saving procedures. One of the drawbacks of simulation-based education is that there's a limited number of people who can participate in each patient care scenario. In an effort to increase the impact of the mock trauma program, we have expanded beyond just the trauma resuscitation itself to include education for ED staff that were not able to participate. This primarily includes nurses and techs. We travel to each zone in the emergency room with mannequins and equipment and go over things such as indications for pelvic binders, how the Belmont works and what information should be conveyed about transfusions, how to place hair traction splints, and issues with pediatric resuscitations. We also provide education about quality issues that are targeted with each mock trauma, such as administration of antibiotics within 1 hour for open fractures. At a baseline, simulation-based medical education is a quality improvement initiative in and of itself because it improves patient outcomes by impacting procedural skills, medical knowledge, clinical reasoning, and teamwork. But the real quality improvement benefits lie in the ability to create a feedback loop for the trauma team members. Through the primary and secondary trauma review processes, we identify quality issues as they develop so that we can specifically educate to and intervene upon those issues in a timely manner. At the end of each mock trauma, I make sure to review the quality issues in question with the team, the importance that it carries for patient care, the impact it has on the trauma program itself, and any changes in policies or procedures that may affect that specific quality issue. We then have the ability to track the effects our interventions and education have so that we can determine whether they're having the desired effect. Quality issues that we've addressed through the mock trauma program include 90 seconds to IO, which is geared at placement of intraosseous access, and unstable patients in the event that IV access cannot be obtained. Emphasis on immediately completing tasks after recognition and the need for after recognizing the need for an intervention, so that we can make sure that they actually get completed. We've had a lot of issues with somebody verbalizing a need for something and then not completing that action. Antibiotic administration for open fractures, Belmont assembly and operation, importance of upgrading trauma alerts and activations in the event that patients become unstable so that the necessary resources can be mobilized. In situ simulation ensures that multiple systems factors and their impacts on trauma resuscitations are considered so that latent threats may be identified before they impact patient care and outcomes. Systems issues encountered include equipment, technology, physical environment, and layout concerns. Routine in situ simulation positively impacts system operations and the safety climate in high-risk clinical settings. In situ simulation has helped identify the need for the ability to transport equipment that's needed for common trauma procedures in the case that a patient deteriorates in a non-trauma bay room down in the ED. It's allowed staff the opportunity to familiarize themselves with the location of specific equipment and can create contingency plans for what to do in the event that the equipment doesn't work, such as the Belmont. It also has helped us evaluate our process for trauma team notification, which is particularly important because early trauma team activation has been linked to improved patient outcomes. This process has been particularly useful for our trauma program when it comes to the Pediatric Readiness Project. This is an initiative that was launched by the American College of Surgeons Committee on Trauma to ensure that trauma centers are able to provide high quality care to critically injured children and to decrease preventable deaths. With children's just down the street, we rarely take care of children, which meant that we were relatively unprepared to care for this subgroup of patients. The project has driven a lot of our mock trauma simulations over the past 6 months. And they have allowed us to not only ensure the members of the trauma team have the knowledge required for taking care of children, but also that we're logistically prepared. In situ simulation has brought several issues to light, such as the need for specific equipment so that we can transfuse blood in children who weigh less than 10 kilograms, determining how fast we're going to transfuse blood into children, and really just the need to clarify our massive transfusion practices in children. Additionally, pediatric simulation has given the trauma team members an opportunity to find where the pediatric cart is located, know how to use the cart itself, which is based on the Breslow tape, but it can be confusing if you've never seen it before, and to talk through specific pediatric case scenarios. One of the main challenges in trauma resuscitation is that the teams are constantly changing. A study at a level 1 academic trauma center demonstrated that trauma teams were never the same, and that on average, about 2/3 of the trauma team members changed between resuscitations. Team familiarity has repeatedly demonstrated improved teamwork and outcomes. Randomized controlled trial showed that though there was improvement in teamwork amongst all teams participating in multiple trauma simulations, Teams that had stable composition had significantly greater improvement in teamwork and clinical effectiveness compared to teams that had dynamic composition. Similarly, team familiarity has been shown to have benefits in multiple surgical disciplines, including decreased operative time in vascular surgery, decreased complications after elective open abdominal surgery, and decreased complications after gynecologic operations. Simulation focusing on team training and interaction facilitates decision-making and improves team performance. There's not a whole lot of data to support this, but this effect is likely more pronounced in the less predictable environment of the trauma bay than in the OR during elective operations. At Anschutz, we're unable to maintain consistent team membership for trauma resuscitations. So instead, we focus on creating a shared mental model of how resuscitations should run. We have created clear definitions of the roles and responsibilities for each member of the team to help reinforce the shared mental model. Additionally, we emphasize the critical information that each member of the team should be communicating to the trauma team leader in order to maximize efficiency and quality of care. Repeatedly emphasizing the responsibilities of each member of the trauma team through simulation reduces the negative impact that lack of familiarity has on the team performance. Team-based simulation training improves teamwork, task performance, knowledge, and provider satisfaction. The emphasis on non-technical skills largely originated from the aviation industry. Non-technical skills refer to the cognitive, social, and personal resource skills that complement technical skills and contribute to the safe and efficient task performance. These were modified by Steinemann into trauma non-technical skills, which we use to assess team performance in traumas. These skills include leadership, cooperation and resource management, communication and interaction, assessment and decision-making, situational awareness, and coping with stress. Trauma resuscitations are high acuity, fast-paced clinical settings in which there's uncertain or incomplete information and also a demand for completion of multiple concurrent tasks. This makes communication very challenging and prone to errors. One study found that communication errors occurred in about 50% of trauma resuscitations, and multiple studies have shown that teamwork plays a critical role in the prevention of critical incidents and errors. Failure of non-technical skills has also been associated with an increased rate of technical errors. Simulation-based education targeting non-technical skills has been shown to improve teamwork and team performance. Specific issues that we address on a routine basis through mock trauma, the mock trauma program include clear delegation of roles and responsibilities, which is completed prior to the patient arrival, as well as preparation for anticipated procedural needs, such as chest tubes, central lines, and pelvic binders, which is all based on the pre-hospital report. Clear identification of the trauma team leader and notification of the room whenever the trauma team leader changes. This helps keep the team oriented to whom they should be communicating with and looking to for instruction. We also emphasize structured handoffs between trauma team leaders when a transition is required. This generally happens when the trauma surgery team arrives in the trauma bay or when the trauma team leader is pulled into a procedure or operation, such as a resuscitative thoracotomy. To assist with these transitions and to keep the team oriented, I modified the IPASS system for use in trauma resuscitations. It focuses on brief communication of the degree of physiologic derangement, the mechanism of injury and identified injuries, which portion of the assessment is currently being completed, and the clinical concerns. This allows the assessment to continue smoothly despite changes in leadership. We also highlight that all information should be communicated directly to the trauma team leader to allow for synthesis of information through a central hub. We encourage closed loop communication, and we encourage team members to ask for help if they are unable to complete an assigned task. This facilitates timely task completion. And we ask the trauma team leader to provide intermittent summarization of the known information in the plan. This keeps the team oriented to what needs to be done to reach the next phase of care and minimizes inertia. Multiple studies have shown that simulation-based team training and non-technical skills improved teamwork and team performance, which ultimately leads to improved patient outcomes. Even though we only have a small portion of our residents who are planning to pursue careers in trauma and critical care, there are multiple long-term benefits to simulation-based non-technical skill training for all surgeons. Monthly trauma simulation with specific focus on non-technical skills has been shown to improve resident leadership skills, crisis management skills, situational awareness, and overall non-technical skills, whereas conventional experiential education and non-technical skills gained through daily work has been shown to be insufficient. Non-technical skills gained through simulation have positive impacts on technical performance in the OR, decreased adverse events both in and out of the OR, and overall improvements in patient outcomes, which will benefit our residents throughout their careers. Overall, the mock trauma program has had positive impacts on trauma-specific medical knowledge, technical skills for clinicians, the trauma quality improvement program, resolution of systems issues that adversely impact the care provided to trauma patients, team performance, and non-technical skills. I look forward to continuing my leadership of the mock trauma program to ensure our trauma patients receive the best care possible and to help develop our residents into strong, competent clinical clinicians and leaders.
Thank you, Dr. Jenson, for a great presentation. Obviously, a lot of work went into that, and a lot of work has gone into the development of this program. So congratulations, and thank you for that. Have a couple minutes now for questions or comments from the audience. We have a lot of trauma experts here. Dr. Cawthorn, any thoughts, comments on how this program's evolved? Let me say, when I was a PGY1 training at Baylor, one of our chief residents, who nobody really cared for, had fallen sound asleep on a sofa just outside the operating room in a little dark area. And one of our PGY2s snuck up and tied his shoelaces closely together, then backed out, kicked the door open, turned on the lights, and said, "Gunshot wound stat, trauma bay 1, you're needed now." I'll leave it to your imagination how it went after that, but it was only slightly more chaotic than your usual trauma activation. So where's this going to lead to us? Where's this going to fit in our training of tomorrow's surgeons?
I think Dr. Jenson, terrific presentation, and I think it really highlights the importance of repetitive training, and that we can really do that through mock scenarios. What do you think the next step of this? Either do we keep it just in the trauma bay? Do we do it more frequently? Is there a way that we should start thinking about taking it to the operating room for that type of simulation?
Sorry.
Yeah, absolutely. So I think my next focus will be really focusing on quality improvement. So simulation has been really great for taking people from kind of the pre-contemplative stage of change. So people tend to think that there's not an issue until you really show them that there's an issue, which is what simulation is great for. So it takes them from that pre-contemplative to that contemplative stage of change. I think looking at ways that we can increase that even more to the action phases of change will be very interesting, and also seeing if there are specific things that we can do that have more impact on patient outcomes. Also, I think it would be very interesting to do a multiple settings scenario. We kind of have some of that, I guess, a little bit with the disaster management drills that we do, but that we don't really take patients to the OR. I know that we also have a lot of issues currently with turnover in OR staff. I think a lot of the people who are working on nights and weekends have not had a lot of trauma experience, which I think has impacted some of our outcomes. So it'd be very interesting to do some trauma sim with the people who are working specifically at those times.
Wonderful. Other questions or comments? I've already demonstrated my willingness to call on people, so I suggest you volunteer. Okay, Dr. Cohen, Time's up. Questions or comments about this presentation and the role of simulation in trauma education?
Yeah, it's really important and really nicely done, and it's really true. We all practice at other things that we do in our lives, our sport, our music, or whatever, and we don't think about doing it in surgery. We just come to work and do what we do. So this is really important stuff. How do you make it real? How do you make it more real? Because there's always a little bit of a disconnect between not really being scared like it's the real thing versus trying to make it like the real thing and feeling like it's just an additional thing that we have to do before we actually go around and actually take care of patients. So how do you do that, do you think?
Absolutely. Well, I think just being observed in the first place tends to give us a little bit of that sympathetic activation, gets the nerves up. I think that the in situ setting helps a lot because it helps us figure out exactly how we're going to approach these things. I also think that the use of our high fidelity mannequins helps a lot, just because we can react in real time to what's going on with the resuscitation. Eventually, I think it would be nice to be able to move to actual trauma patients, or using real people for our simulations. That definitely increases the buy-in. But overall, it has been shown the difference between using real people and high fidelity mannequins doesn't have, there's not a real difference in impact. As long as we have a fairly high fidelity situation for things like medical knowledge, decision-making, leadership, that's had adequate, results. So I think that we could make some changes, but overall, I think we're doing a pretty good job of making it seem real.
Thank you so much. Again, wonderful presentation. Thanks so much for that and for the work you're doing. Our next presenter is going to be Dr. Brian Caldwell, and Dr. Caldwell does urology training at Stony Brook, and then came to the University of Colorado for a fellowship in pediatric urology, and now has developed a really extraordinary practice down in the Springs where he sees patients in what is in many ways a community setting. However, still brings complex cases up to the university, works with residents, works with fellows. And I think in many ways it's sort of structured the best of all possible worlds, but that's only one practice model. The face of where we all practice, where our trainees practice, where we'll go when we complete our residencies and fellowships is evolving at a very rapid pace. So Dr. Caldwell, who is an associate professor of urology and surgery, looking forward to your presentation and welcome. Thanks for being here.
Hello. Thanks for letting me talk today. I can figure out how to do this. Okay. No disclosures financially. A few objectives. We're going to evaluate some of the surgical practice models that are out there, analyze kind of our education of residents and fellows on this. And then hopefully afterward, people can implement a plan for successful OR management and general clinical practice. This is not a heavy data-driven talk because there's not a lot of data behind this. It's a lot of generational kind of word of mouth, carrying on, no real perfect defined technique. It's different for every specialty, but there are overlapping principles there. It's continuously moving, rules change. But I want to say I'm not the holder of all knowledge on this. I've built a practice myself, as many of you have out there. And there's many models, as Dr. Meacham said. So I was going to start with a kind of a general state of the surgical workforce, where we are with things, kind of some of the challenges on the clinical side of things, challenges on the non-clinical side, why am I here, and then some basics on practice development. The last part's going to be mostly directed toward the residents and fellows. So what's the state? There's some things we do really well. We train surgeons clinically well, although I'll talk about some of the challenges associated with that we've seen in the past and are still dealing with. We do research well, we drive forward medical knowledge, we teach others how to do research. We, at minimum, teach people how to understand research. We embody education. We teach everything from medical students to nurses to residents to fellows to each other. I always say I would teach anybody who would listen. I think many of you are the same. We collaborate, and hopefully we inspire some people to follow what we're doing. Things we don't do quite as well, I think, overall. Have a structure for telling people how to get jobs, how to set up practices, how to build your practice, coding, billing, general financial landscape, understanding the business of medicine. So in 2009, Dr. Bell, and this was shortly after I kind of got into residency, he was executive director of the American Board of Surgery. He identified that a lot of people were not prepared for practice afterward, not uniformly prepared. And a few things that came to light and things I thought about that may be impacting that are workout restrictions, just not having the exposure, increased oversight, and litigious society, all which limit our trainees' autonomy. If trainees' autonomy is limited, they're less comfortable doing operations and doing clinical work, which becomes an attending, you're less comfortable, and then you don't let trainees do as much, so less autonomy. So it's a vicious cycle that occurs. There was an article that looked at this in 2015 and added a few more things to this.
It's still your microphone, brother. I'm gonna keep this.
Oh, okay, thanks. Thank you, Dr. Meacham. Added a few more things to this, including some of the cost drivers for medicine and our own busyness that occurs and decreases the amount of teaching time we have. So what are the results of some of these? People go for fellowship. So if you look at practicing urologists, about 42% of those have a subspecialty. If you look at that 15 years ago, you would see that number being much, much lower. General surgery residents, 80% of those go on to do a fellowship. And the sad kind of statistic after that is that 55% of those do not feel comfortable starting independent practice after residency. So what are the things people can do? They can do a fellowship. They can stay in a protected environment, meaning with places they've trained or people they know who can shepherd them along. There's even a Master of Surgery program that the American College of Surgeons has. It focuses on both clinical aspects of experience as well as non-clinical experiences such as practice management, billing, medical legal, as well as providing mentorship and leadership experiences. And the goal really is to get people early autonomy and increase the satisfaction of their practice. Looking at just numbers, we're in short supply. Just numbers for things, general surgery is about 25,000 general surgeons who are actively working. If you look at the blue bars, those are active physicians. The red are how many patients there are per physician. And then in urology, just because that's close to home for me, it's about 10,000. What we're seeing is a projected shortfall in this of 150,000 total active surgeons. We're looking at somewhere between a 10 and 20,000 projected deficit over the next 12 years. This number is actually decreased with the expectation that the GME is going to increase funding for this. If that doesn't happen, this number will be substantially worse. There's also disparity in where we work. Metropolitan areas have a much higher rate. Rural areas, because of this, are suffering more and have less access. So here's some urology specific data. By next year, there's a projection that we're going to be about 3,600 urologists short. About 60% of US counties across the US don't have a urologist. And there's some factors for the shortage which go along with urology and general surgery. Aging workforce, the average age for urology is about 55 to 59, and 30% of those are over the age of 65. If you look at surgery in general, it's about 25%. If you look at the population in general, it's about 16%. There's also an aging population, which may disproportionately affect urologists. If you have a prostate and you get old, you're going to need a urologist. So if you look at by 2034, about 10 years from now, almost half again as many people will be over the age of 65. There's also rural disparity, just like we saw on the general surgery side of things. Only about 7% of these younger urologists, which they consider 45 and below to be younger urologists, only 7% of those practice outside the metro area. It's not unique to urology and general surgery. If you look across the surgical spectrum, so the blue bars here are the percent over 65, the gray bars are the percent under 40. The only one that does not follow suit is the sports medicine. So why is there a shortage? Probably not training enough residents. Aging workforce, as we already mentioned. Changing demographics of trainees and new attendings. These people may want to live in areas that are more metropolitan. They may not want to work as much and be in the hospital as much as people did 30 years ago. And then burnout. Burnout is a double-edged sword because not only does it create shortage, it creates shortage, but it worsens the shortage as well. So there are some initiatives to help from some of the societies to try to increase number of GME resident spots, as well as money supporting this, improve reimbursement, which seems to be going down every year. We're still at a Medicaid model in the 70s. And then also mental health for burnout. So going back to this master surgery program, the chief wrote an article and talking about early autonomy and how can we affect the workforce in this way. And it's not just this program I'm talking about, but it's in general, clinically being ready as well as being ready from a non-clinical standpoint. Hit the ground running in practice would be the key. Program directors agree. Survey data, about 87% said we should be teaching this more. They also believe that most of their residents were not prepared to walk out into practice with, from a business of medicine standpoint. But the good side is there is some data to support that some focused education can improve this through lectures, through web-based curriculum, even through coding accuracy monitoring, having residents code, check that coding. They saw a drastic increase in how well they did with this. The funny part is the program director for that also saw a substantial increase in his accuracy in his coding. So why am I here talking about this? As Dr. Meacham already mentioned, I started as a new fellowship graduate, a new site of practice. There was my boss, Dr. Wilcox, did one clinic day a month there and did no OR. Today we have daily pediatric urology presence, 2 attendings, 2 nurse practitioners, 2 ASCs, 2 nurses, and then we have 9 full OR days a month. And the 2 attendings cover this. These 2 attendings also were only part-time in that location. 2 years into practice, we opened a freestanding 100-bed children's hospital. I was a pediatric urology lead for this build. It's a unique experience that I think most people don't get to have. And we also take complex care to our patients. We have a multidisciplinary clinic for congenital anomalies of kidney and urinary tract, as well as spina bifida spinal cord injuries. This is just our clinic visits for this clinic. I started in 2016, late in the year, and you can see the increase. 2003 dropped because we lost our APP and had to get a new, and it took a while. So this part's more for the residents fellows. Some of the basics of practice development, some of the things I've learned as I've gone along. Like I said, there's not a lot of data to say this is what you have to do, but at least there's some of the things that I think can go across all. There are many paths. You can go to academic practice, private, you can do a solo or small group, you can do large groups, multi-specialty groups, you can do hospital employed or hospital-based practices. Location. I started my training in Chicago in medical school. I did general surgery in Oregon. I did urology in New York, and I did my fellowship training in Denver. I've had an interesting cross-section of the US because there's different practice patterns across different sites, as I'm sure a lot of you know. If you're looking at urban versus rural, urban, do you need subspecialty training to be marketable in those areas? If you're rural, you're gonna have the mentor and support directly out of residency or fellowship to pull that off. Important things like significant others, where do they want to be? Payer mixes, reimbursement models, call, mentors, et cetera, et cetera, et cetera. This is too short of a time period to go into detail on a lot of these things, but they're things we should be thinking about. There's really a lack of a good playbook for this. There are some resources out there. A lot of the specialty societies will have resources on their websites, courses you can take. There's, again, that mastery in surgery program. And the thing I was talking about, that the article I was reading from the chief for there was saying that they're trying for this program to develop one of those playbooks for the general surgery practice. My best recommendation, find mentors. Find mentors in your training, find mentors in your new practices. The hard part sometimes is your practice, your training is in academics. Most people do their training in academic centers. Your practice might not be. Up to 50% of us practice in private practice settings. So finding a job. Use people, use your mentors from residency, fellowship, medical school to help you find those positions. Improve your academic reputation, publications, presentations at meetings, meet people at meetings. It's a low stress way to start the process. When you're looking at jobs, remember 2 out of 3 in bed. You get your location, your job compensation. If you get 2 of those, you're doing pretty well. There's very few ideal jobs out there. So you come for years of delayed gratification through medical school, residency, maybe fellowship. And then one day they say, what do you want? So you have to start looking at yourself, identify your own strengths, understand what you love to do, what you're good at. And then also, I think equally as important is know your own limitations. The job directs some of these things as you go along, so choose wisely, but it doesn't mean that you're going to stay in that job forever. About 50% of people leave those jobs within 2 to 3 years. For urology specifically, our board testing is after 18 months of practice. So a lot of people will change after that if they're in an unhappy position. So you probably heard the 3 A's to physician or surgeon success: availability, affability, and ability. I think there's probably a couple more: affordability and accountability. We're not going to talk about those today. So availability, be available to patients, be available to referring providers. Patients need a path to get to you. Referring providers, you can give direct access to those important people. When I was starting my practice, I gave my cell phone number to our NICU and our hospitalist in Colorado Springs so that they could contact me directly. I was pleasantly surprised nobody has abused that in off hours. So one of the things about being available, one of the hospitals I was talking to said, another urologist came up to her and said, well, why don't you send me more referrals? And the answer simply was, because I always answer. Affability, be personable. Be personable with your patients, your staff, your colleagues. That word spreads. Be likable, be nice. And I think that's the hardest thing about being nice, is during those times when you're stressed. So when you're busy, when you think it's not a good question, when you're tired, and always be nice to your staff. They're the ones that take care of you. Ability. They're not going to see if you have the ability unless you do the other 2 things I talked about. Establish yourself clinically. Be clinically expert. Define your reputation. Be confident. Communicate with your referral base well. Be proactive. And what I mean by proactive is set yourself up for success. There are a few ways you can do this. A couple examples are, during your residency and fellowship training, take notes of your setup, your instrumentation, your OR, what happens in there and how people do their exposure. I think those things will help you in your practice as you go forward. Get your board certification. So there's many ways to embrace your referral base. For me, I did several talks. I'm on committees in the hospital. I even did a podcast through Children's Hospital. Communication, make referrals easy yourself. You have a little more flexibility with this if you work in a smaller environment. If you're in a big hospital like this, referrals come through a centralized location. But make seeking that advice easy. Our new chairman in pediatric urology, Nick Cost, is one of my mentors and has, it's always been impressive to me how he's created his practice, and his communication with pediatricians is, I think, the reason he is so successful at it. You can give your cell phone to people. You can leverage your MR. You can but always make sure you're timely in responding to people. Follow up. You can have these things built in automatically to your EMR. Take time to speak to people. I think we get busy with our lives. We get busy with our practices. Remember, people are asking you for help. Always remember, this is also how you're going to get your patients. I know, especially in residency, you can get overworked and disgruntled, and some of these things lose sight. But those are really important things to take with you out into practice. Be nice. your clinic. So I'm going to go over kind of nuts and bolts of your clinic, nuts and bolts of your operating room, just a few things. But you want to be involved in your staffing. You need to pick out your roles, how people are going to work, how you're going to use your APP. There's many models for this. If you have one in clinic, you can bill off their notes. You can have them be independent. You can have them in the hospital. You can have them in the operating room with you. Something I learned early in practice is if you're going to have a nurse practitioner in clinic or in the operating room with you, they have to have sort of special training above what a PA does. How are you going to use your nurse? Are they going to be a history taker for you? Are they going to be a higher level function of a coordinator? Are they going to set up your procedures? Are you going to have an MA? How are you going to use them? Or our scheduler, they run my life. Be nice to them. Give them a lot of autonomy to take care of you. If you're in a private practice or a smaller setting, do you need a practice manager? Tips for your clinic: be as involved as much as possible in getting your staff. So the way I work is I'm inside of Children's Hospital, so I don't have hiring status over people. But I'm closely involved in the screening process for hiring, developing roles, as well as trying to maintain scope of practice for the people. A few things that I think are really important. Empowerment. Empower your people. I don't know the best way for nurses to do their jobs. So I ask questions. I empower them to improve our process. Support. Always have their back, even when they make mistakes. And then show appreciation. It doesn't take much to a cup of coffee, a lunch every now and then. And they'll do things for you. So this was my clinic in the middle of COVID, or at the beginning of COVID, in the red box. Within a day, I told them I wanted to switch everything to telemedicine. And I did almost nothing. And they jumped in, worked, and turned it around. By the next day, I was doing telemedicine, and we saw 2/3 of our patients. The OR, what do you want? You want block time. You need block time. You need to understand how you get it when you get a job, what you're going to do, how you're going to keep it, and how you can lose it. Instrumentation. It's a really good idea to take your mentors' instruments, look at what they use, understand what they use, understand the names as you go into practice. Nursing and scrub leads, get to know them, use them. They can take good care of you. Who's going to be your assistant? If you're in an academic setting, you've got built in with residents and fellows. If you're going to be in a private practice, are you going to have an APP assist you? You're going to have a first assist? Or are you just going to be working with a scrub tech who you've never worked with before? Preference cards. Number of times I've heard, well, it's on your card. That's what the preference card says. Well, make sure it's what it says, what you want it to say. A good thing to do is take those from your mentors. Take them and make them your own. And I think the last thing is, who and where is your backup? If you're in the operating room and you get into something that's a little more than you can handle, who are you going to call to come in and give you a hand? Or who are you going to call to ask a question? General tips for the OR: be on time, start on time, stay on time, especially early in your practice. Nobody knows how long it takes you to do something, so build a little extra time in there. Get some wins with some simple cases before you put on the most complex case. This wins over the OR staff. And then they'll expect that if there's a complication or there's something going on, that you're a good surgeon and they're going to back you up. If you lose your OR staff, it's always hard to win them back. Use as much of your block time as you can. That way you keep it. Just be reasonable, be confident, and help out in the operating room. A little bit of help turnover, everybody points the same direction and then speeds you along throughout your day. You don't like how things are going? Get involved in the OR committee. Do something about it. Call it practice for a reason, because we're constantly evolving, constantly changing. I learn something new every day, I feel like. Be flexible with what comes. Just a few basic take homes. Use people in a good way, especially your mentors. You get your mentors in training. Make sure you have mentors early in your practice as well. Established practice is just communication and establishing relationships with your referring providers, your colleagues, your staff, leadership. Understand what your community needs. You can be in a rural setting, you can be in an urban setting, you can be lots of different practice models as we talked about. Understand what's needed and understand the expectation of your referring physicians. From my standpoint, my example in Colorado Springs, has a small town mentality. I understand this because I grew up in rural Kentucky. It's not a small town, but they like to keep patients there. The pediatricians are very specific about it. A lot of patients are scared to go over Monument Hill. They don't like to go to the big city in Denver. They don't want to drive. So keeping care there has been my main goal. You're selling yourself. Introduce yourself, be persistent, be timely. I like the saying, you are your own brand, and especially as a surgeon, you are. For me, when I started, I rounded in the NICU, I rounded with hospitalists, I did outreach to try to get my name out there and get my brand out there. Billing, we could go on for a long time about billing and billing appropriately. But the bottom line is bill appropriately. We all get busy and have a tendency to underbill so that we don't overbill and get in trouble. But make sure we bill appropriately. It supports everything associated with your practice. It supports your staff, it supports your hospital, it supports yourself. One of my residency mentors always said, don't overbill, but make sure you get paid for what you do. There are many, many resources out there for billing and coding. I don't think we do a great job in residency and fellowship with really giving hands-on training for this. I think we can do better from that. Start this during training so that your first day in clinic is not overwhelming trying to figure out your clinical practice as well as figure out your billing. Happy staff, happy practice. Take care of your staff and they'll take care of you. I think we do a good job in our children's urology group by having employee appreciation as well as retreats where they can help to improve our practices. We went to school to be doctors. We didn't go to school to be managers, but that's inherent to our jobs. Take some time, read some books, take some management courses, some leadership courses to figure this out. I think it'll serve you well in the future. What did I learn specifically? Ask questions. Ask it to everybody. Ask your mentors, your colleagues, leadership. I was pretty laid back. I found out I needed to be more assertive at times. Because I'm laid back, when I am assertive, people actually listen. I do this when I'm advocating for patients, when I'm advocating for my staff, or when I have to advocate for myself. Find your niche, be flexible, get involved. I think everything has to line up. We talked about the clinical challenges that can occur as well as some of the business side of medicine challenges. So have confidence in your clinical skills, understand the business of medicine, identify your mentors throughout, and then you hit the ground running. Thank you guys for your attention. Let me know if you have questions.
Questions or comments from the audience? Brian, really nice presentation. So I've got a quick question. At least in the adult side of urology, I'm guessing, well, I know in plastic surgery and some other specialties, it's probably coming to more areas. The development of private equity groups in the community has had a really dramatic impact. If you run across any commentary about what that's going to look like in the future of practice development?
Great question. I've seen it, how it's affected practices across from, when I was in New York, it was really starting to snowball. And then in Colorado, as I think it's been big changes across the landscape here. Colorado Springs is the urology practice groups have been taken over by a lot of the private equity groups. I think the biggest thing that's going to be a challenge with that is it going to be cost saving metrics that are going to be implemented. And I think the work for value is going to be harder to achieve. So there's going to be more work expected and not as high a reimbursement as we have had in the past. So I think you're working more for less is my understanding.
Probably going to be the case. Joe Cleveland, I'm about to inflict a question on you. Give you a second to prepare. As you developed your practice, what are two things that you would have done differently if you could go back and do them all over again since the day you finished your cardiothoracic fellowship? Actually, I'm sorry, Joe, I asked that question and I gave you no microphone.
I think I would have defined a focus a little earlier. I think Brian did a nice job of talking a little bit about kind of getting your word out there to be everything to everybody, but also I think you mentioned kind of focusing on some things to really gain some expertise. So that I would have done earlier. And then I think I would have learned more about the need to understand hospital dynamics and how it's going to affect your practice. Those two things.
Okay, thanks for a very nice presentation. Thanks for comments from the group. We are adjourned and enjoy the rest of your Monday. Thank you.